We'll talk about humeral shaft fractures. Let's start by this case. This is a female patient, 30 years old, fell into ground, neurovascular intact, with mid-shaft fracture humerus. Who would like to fix it? Okay. Who would like to do nothing or to do conservative treatment? Okay. This is another case. ده الأساسي بيه.
أنا يا جبس يا أحط له اكسترنال فيكسيشن. حاجتين واحدة.
Okay.
لأن الاثنين اكسترنال فيكسيشن.
Yes.
يعني كونسرفتيف.
Yes. Okay. This is another case. Male patient, 34 years old, fell from height with radial nerve pulse. Who do fixation with emergency radial nerve exploration? Okay.
لا برضه هحط له اكسترنال فيكسيشن من غير ما اعمل حاجة.
Okay. Okay. The learning objectives is to assess this fracture, when to do conservative, when to operate, and tips and tricks in operative management. Okay. How to assess our patient? This is the humeral shaft. This is the zone extended from just distal to the tuberosity till the supracondylar ridge. It's a field of nerves. Special consideration to the radial nerve, who comes from posterolateral, crossing the spiral groove and runs anterior and anterolateral in the distal third. This is the common mode of trauma, direct fall into ground, but it may come from RTA, especially in young ages, also by twisting injury in athlete. This is a common associated injury come with the radial nerve. It's about 8%. It's a radial nerve palsy. Wrist drop with loss of sensation at the dorsal-radial palm. This risk increased by Holstein-Lewis fracture. This fracture describes special consideration where the radial nerve entrapped when it comes from posterolateral to anterolateral at the fracture site. Increase the risk up to 22% of radial nerve palsy. Vascular injury is uncommon, but it's common in multiple injuries like floating elbow. So special consideration to this type of trauma when you see it, you have to exclude vascular injury not just by pulse, but also to exclude by ankle brachial injuries. Soft tissue injury. Soft tissue injury is very important. Not all closed injuries the same. We have a classification from grade 0 to grade 3 according to energy. And also open fracture not excluded in the upper limb. We have to see it. This is a proximal humeral fracture, not pure shaft, but with open fracture at the axilla. Okay, we have to classify these fractures in order to manage. This is a common AO classification, classified 12, A, B, and then C, according to the simplicity of the fracture, simple to simple wedge, and finally the complex. This is another classification by Garnavos. He gives special consideration to the segment, either proximal, middle, distal, and transition zone between proximal middle and middle distal, which is very important in approach and fixation. Okay, when to conserve? The conservative treatment has a role? Yes, the conservative treatment has a role in non or minimally displaced fracture, acute, closed injury, and isolated fractures. Different patterns like functional bracing, arm sling, and so on. And it have a better functional and outcome. The operative treatment, when it failed conservative, when there is multiple fracture, open fracture, pathological fractures, and associated vascular injury. So what about the radial nerve? Like Professor Gamal say, radial nerve is not an indication for exploration, except if there is associated vascular injury, penetrating open injury, or Holstein-Lewis fracture because there is an entrapment, or if there is progressive radial insult and relative indication was high energy trauma. Okay, how to manage? How to select the approach? This is the first point. The approach is related to the segment of the fracture. If this is the zone, if it in the middle, we can use posterior, we can access anterolateral approach. If it in the proximal, blue zone, anterolateral approach is more accessible, but posterior is not extensile to the proximal part. Also, soft tissue and neurovascular is important to select the approach. This is fast trick about the posterior approach. We all know it. Radial nerve exploration is mandatory in this approach. This is the anterolateral approach, extended from the deltopectoral approach. We go between the brachialis and the mobile wad brachioradialis, and the radial nerve exploration is at the distal 1/3. Okay. What do you think about this fixation? Is it okay? Okay. Yes, it ends up with non-union and implant failure. So we need to know what happened. Failing to plan is a planning to fail. We have to plan everything. This is a two types of fixation, absolute and relative, and everyone has a consideration. If you want to do absolute, you have to select firstly the fracture pattern. It must be simple fracture. You have to do anatomical reduction. Anatomical reduction means no gap. You have to do it directly, and after that, you have to apply the principles of the plate fixation. The relative stability, you can do it in simple and complex fractures. You have to do functional reduction, direct or indirect, with special considerations to the fixation. So, the final step, the nailing. Nailing is very minimally invasive and has a lot of value because it's minimal. Mainly used in pathological fractures, but may used in upper third fractures, comminuted or spiral fracture. You have to consider the nail entry to protect the rotator cuff, give your entry to be more anterior, to be more parallel to the supraspinatus, and protect the supraspinatus tendon at the whole surgery while you do entry point, reaming, and so on. Okay, this is the end of the surgery. Going back to the first case, like Professor Gamal says, casting or extended fixation. Okay, we do functional bracing, conservative treatment. This is after 6 weeks. This is the patient starting pendulous movement, and this is the patient after 3 months with union. So the conservative treatment has to be done. This is another case with mid-shaft fracture, displaced. And this is the applying rule of absolute stability, anatomical reduction, no gapping. Okay, and this is after the healing. This is a third case we started with. This is a case of radial nerve injury. This case comes after 3 months with complete recovery of radial nerve, but not non-union. So like Professor Gamal says, we don't have to explore every radial nerve also. Okay? This is a comminuted fracture, so we do relative stability, bridging, plating. Okay? Final case, proximal third. We have to choose anterolateral approach and bridging plating also. And this is a final X-ray after 3 months. Okay, so our take-home message, first, conservative treatment still have a role. Fraction level detects the approach. Interfragmentary screw may be used with bridging plate to the main fracture. And finally, absolute stability with gap reduction equals failure. Thank you very much.